85% of workers are reporting that they're experiencing burnout or exhaustion, and nearly 47% have actually taken time off for mental health reasons. So a lot of the times when people are going through something hard, we just say, well, just reach out, right? Just reach out, or something that sounds nice, but a lot of people are struggling silently. When you make mental health $0, that is real access. That is saying to your team, like, we care about this and we want you to use this, and we're not going to ask you questions that make you uncomfortable. The more open that you can be with your teams about mental health, that goes a lot further, honestly, than any plan design decision could.
The Business of Benefits is your no BS, no sales guide to real solutions.
No gimmicks, just the truth about how to take control, transform your benefits, and care for your most valuable asset, your people.
If you're tired of the same old sales pitch and you're ready to rethink your benefits, this podcast is for you. The truth is out there. Are you ready to hear it?
Welcome to the Business of Benefits. I am your host, Chelsea Ryckis, and today we're talking about mental health. So mental health is one of those topics to me where it always really just kind of seems like pie in the sky, foo-foo, and not really like data driven. I know all the mental health vendors are going to be hitting me up after this, like, don't say that, or our product is. But nonetheless, I want to go through today kind of where we stand with mental health in general, some of the compliance around mental health, and then I want to share a quick case study for a client of ours where they basically created untethered access to any mental health that an employee would need, and talk about how those claims performed in comparison to a plan where maybe there were more restrictions on access to mental health. Before we get into that, though, I want to thank today's sponsor. International Foundation of Employee Benefit Plans has a designation. You guys probably already know about it, the CEBS. I always laugh because there's so many acronyms in our industry, and then especially the International Foundation, they've got a ton of them. But they're educational, right? They're a school. That makes sense. But in a field as complex as ours, experience alone isn't always enough, which is why professionals turn to the Certified Employee Benefit Specialist designation. And if you're in the industry, you know that that one's a big deal. It takes a lot of time to get. It's not one of those go online and really quickly knock it out, and now you have some letters after your name. It is really equipping you to lead with thorough, in-depth knowledge of employee benefits. So set yourself apart with designation. It definitely speaks for itself. CEBS.org. All right, let's get into today's episode. So mental health, I think everybody knows, is a problem, right? Whether that's burnout, attrition, absenteeism, those tend to be the main HR pain points. A lot of the times, HR is really the one that is fielding the brunt of. Not only are they fielding the complaints from employees about maybe lack of mental health benefits or lack of access to things that people actually need, but they are the ones that are seeing the results, the effects of lack of mental health support every day. So there tends to be an underutilization of EAPs and mental health offerings in general. And I think a lot of that is the stigma around, is my employer going to know that I'm using this? I don't want anybody to know I'm on anxiety or depression medicine, or I have a bipolar diagnosis and I don't want anybody to know, or whatever it is, right? And there's a lot of cultural and structural barriers that limit mental health support. So how bad is it really? Well, 85% of workers are reporting that they're experiencing burnout or exhaustion, and nearly 47% have actually taken time off for mental health reasons. At Ethos, we actually, mental health days don't go towards your PTO. If you need a mental health day, you ask for it, you take it, no big deal. I think that's a really important thing in companies, but however you have it structured is fine, as long as people know that they're, allowed and that there's space for them. Companies with higher burnout levels, they're seeing 23% more absenteeism, and get this, this is the kicker, 3 times the healthcare costs. That's a lot. U.S. workers with fair or poor mental health miss nearly 12 unplanned absences per year versus 2.5 days for healthier peers. I've heard a lot of people say too, since COVID, and then next comes the mental health conversation. And I think that's very valid. I can't tell you how many HR professionals I've heard say that since COVID, we've seen a giant spike in what people are requesting in terms of mental health. So as everybody knows, turnover is very, very costly. Replacing an employee is anywhere between 50% to sometimes double their annual salary. 29% of absences are due to mental health issues, with burnout related absences averaging 4.5 days per year, while 98% of mid to large companies offer EAPs. Anybody know how many people are actually using them? 4% of employees. And that's actually relatively high compared to some of the statistics that I've seen. 4% of employees are using EAPs. Yet it tends to be one of those things where I hear people constantly saying, well, tell me about your EAP. EAPs, guys, very often are not enough. It needs to be more structural in the plan design, which is what we're going to talk about here in a second. So a lot of the times when people are going through something hard, we just say, well, just reach out, right? Just reach out, or something that sounds nice. But a lot of people are struggling silently. When they do reach out, hopefully to a provider and somebody that can actually help them, there tends to be long waits, right? A lot of people around the country are experiencing long waits or tight networks for mental health professionals, or a lot of mental health professionals actually don't even take insurance at all. I've experienced this firsthand. I think over the last 10 years, the 2 times that I engaged with therapy, they refused to take insurance. That sucks when you're paying out of pocket and going on a weekly basis for however long you need to go, right? Really, really sucks. Not ideal. And without support, providers, a lot of them can't keep up with the rising demand either. Interestingly enough, I don't know what this says about me, but all the people close to me in my life, my sister, my 3 best friends, actually are all therapists. Some of them are psychologists, some of them are mental health clinicians, and then some of them are social workers. But every single one of them, this is what they do. And I hear from them constantly. The issues around insurance, self-pay, high demand, etc. So one of the ideas is getting the plan design to actually support mental health. And instead of it just being in employee assistance program, that's the EAP, that's attached to like disability or a life insurance program. Those are great and you should absolutely have those. However, what would it look like to open up mental health coverage on the health plan specifically? And what would that do to claims? Let's dig in. So now we're going to get here into the employer case study. So here's the power of plan design. The data that we're going to talk about today, it covers October 11th, 2022 through June 10th. So that's nearly 3 years of utilization, 2.7 years to be exact. This specific company they fluctuate between 350 to 380 or so insured. It's a manufacturing company. And giving this data, it has strong statistical weight and insight into the population-wide engagement, being that it's close to 3 years. So let's talk through what a traditional plan design looks like when it comes to mental health. If we were just to look at, any type of, especially a shelf plan, right? Like a Buka package plan that we're going to pick up off the shelf, the copays per visit might be $25, $50, $75, which, when you look at it, you're like, okay, that's not so bad. Coinsurance, 20 to 40% usually after deductible. Deductible, which can be, as we know, quite literally anything, never mind high deductible health plans, but let's say ranging from 500 to 5,000, I've seen even. And that's typically required before the coverage will kick in, right? Especially if you're on that high deductible health plan. Session limits. This is incredibly common. You'll see 6 to 8 sessions per year. Sometimes it's unlimited, but that can be rare. The limits is really one of the sticking points for a lot of people, because what's to say that within 6 sessions, you're over your traumatic experience, or you might just be kind of starting to catch ground and get your feet running, whatever that analogy is that I clearly cannot find today. But you're starting to feel good, right? And then that's when your insurance is like, nah, no. We're done now. But if you have something else that's different, come back with your next problem. Pre-authorization, this is often required for specialists or intensive care, which, as we all know, can oftentimes, pre-auth is said to protect the plan and protect the patient, but really a lot of the times it's acting as a barrier to care. There's a lot of information and news out there about how pre-auths have literally been used by large insurance companies as a way to control their cost and just inhibit the care that people need. Provider networks. A lot of the times these are narrow and they're limited in-network only behavioral health networks, which again, don't really open up to maybe some of the specialists if you're dealing with something more complex, right? So that's the traditional plan design. Let's talk about the case study plan design. So this client of ours, they saw through the claims data. It was what the claims data showed us was inpatient mental health visits, a lot of outpatient, tons of outpatient mental health visits, and then a lot of depression and anxiety medication on our RX spend, higher than average. So that's when the decision was made. Let's go ahead and just make mental health completely free. So what does that look like though? The case study plan design, copays per visit, $0, coinsurance, 0, deductible, 0, session limits, unlimited, pre-auth, not required. Provider network, open access, see anybody you want, we will pay. This is a reference-based pricing plan, by the way, which really helps with that. I want to just really stick to the pre-auth not being required. That's a really interesting piece. So here's what happened. When you make mental health $0, that is real access. That is saying to your team, like, we care about this and we want you to use this. And we're not going to ask you questions that make you uncomfortable. We're not going to know about it. Just go feel better. Go get better. So there was 100% of claims that were covered with 0 member out-of-pocket costs. How many claims total? 594 total mental health claims. These consisted of inpatient and outpatient, and again, unlimited number of visits were covered. So this approach removed financial barriers. It allowed employees to seek care timely and consistently, right? We didn't stop them mid-treatment. 41 unique employees utilized the benefit. That's 12% of the population, which remember, if you remember what I said earlier, the national benchmarks of utilization tend to be around 4%, sometimes even lower. So 12% is significantly higher than 4%. And additionally, each member averaged 14 sessions. That was the average, 14 sessions. And remember, on that traditional plan design, you tend to see session limits at 6 to 8. So literally, we need to double the amount of sessions for the average person. And again, services included everything from just routine talk therapy. Some of that was done virtually, some of that was done in person, to hospitalization, partial hospitalization, full hospitalization, proving that the benefit was serving mild and acute, more emergent needs for mental health. Some of the diagnoses that were treated, we had 191 claims that were under the generalized anxiety disorder. We had 139 claims that were more just counseling support, life stressors, more of that like acute, I need to talk to somebody type of care. And then 76 claims fell under bipolar depression. So let's talk about ROI and wrap this up. Really strong ROI. So the total cost over 2.7 years was $76,574 for this employer. When you break that down per claim, that average cost per claim was $129, which is absolutely nothing, like pennies, right? The annual plan cost, just under $30,000, $28,745. This turned out to be 2.2% of paid claims. So let's break that into a PEPM. For a 350 person company, that's less than $7 per employee per month, which is a very low cost, high impact benefit, boosted morale, boosted retention, productivity. The industry benchmarks show $14 to $17 per employee per month mental health for traditional, more reactive programs that actually put more cost share on employees. All right, so let's say that one more time, right? Traditional plans, which we talked about, have the pre-auths, the limited numbers of sessions, the copays, deductible, etc. Those plans that make it harder to access mental health care are showing benchmarks of $14 to $17 per employee per month for mental health. This plan, which again opened it up completely, said anything you need, go get, we will pay for it, $7 per employee per month. Interestingly enough, this employee was actually awarded the USA Today Top Workplaces 2025 and ranks in the top 1% of trust in leadership. Let's quickly talk compliance. How does compliance fall into all this? Well, you've probably heard of by now the Mental Health Parity and Addiction Equity Act. That's 2008 and then updated in 2024. It's a federal law that basically says that mental health and addiction treatment must be treated the exact same way as physical health in employer-sponsored insurance plans. So if you're offering a health plan that covers mental health or substance abuse issues or services, then the plan must treat that the same, meaning it needs same copays and deductibles as your PCP and your specialists. It needs same visit limits, and it needs the same pre-authorization rules. And any employers with more than 50 employees have to comply. Smaller employers can be exempt, but there's still some parity with state laws. And then some exceptions will apply for self-funded church plans or grandfathered plans, but those are less common. And honestly, as we've already seen with this case study, the ROI is there. There's absolutely no reason not to consider doing this. And you don't have to do it the way that we did, right? Like you don't have to completely open it up. You can get standalone vendors to come in so that the claims are being driven off of the health plan if that's how you prefer to do it. Or if your population is higher risk with some of this, there's a ton of different ways to approach this. This isn't the only way, but I think it's nice to see that you can do something really, really good for your employees that they need and it not be a huge chunk of change. So to wrap up mental health parity, you cannot put stricter limits on mental health care. Like you can't require people to jump through more hoops to get mental health care than anything else. And you can't have worse coverage for therapy than for things like surgery or diabetes care, etc. So it sounds simple, but I can't tell you how many times I've seen some pitfalls on plans where there's very good intentions and the TPA or the carrier is like, yes, you're all good. And then you look a little bit deeper and here's some of the common pitfalls that I've seen. More restrictive prior authorizations versus medical care, narrower provider networks. This one you're seeing in a lot of lawsuits, or less reimbursement for mental health. And then different step therapy requirements for medications. That's one that a lot of people aren't looking at and making sure, like, is this how it works on our health plan right now? And then inconsistent non-quantitative limits. Those are those NQTLs, such as utilization review processes. There's more enforcement happening now with this, with parity enforcement, and that's with the DOL and HHS. The audits, especially for self-funded plans, are increasing. We are seeing that. So if you are a plan sponsor and you want to make sure that you're super in compliance with mental health parity, confirm parity compliance with your insurer TPA. Don't just take their word for it. Get their word, document it, put it in your nice little fiduciary file, right, under compliance. But then what I would recommend would be take your plan documents, your plan description, and upload it into an AI and ask it, are we meeting mental health parity requirements? And just see what it brings back. It could be right, it could be wrong, double check that too, right? But request a comparative analysis for NQTLs. This is now required anyway under the CAA of 2021. And then the big one is going to be review the provider network adequacy and those reimbursement standards. You cannot have, normal networks versus mental health networks. You don't want a big disparity there. You can't have a big disparity there under this. And then I would also audit EAPs and any carve-out vendors to ensure that they meet parity if they're the only source of benefits, mental health benefits in your program. So let's talk through your takeaways for today. Number one, it's far more effective and affordable and practical to support your entire population and design everything around what they actually need than to try to restrict it, thinking that it's going to save you money. What ends up happening is people delay care and the claims are much more catastrophic than they need to be versus those smaller, right, $129 claims. We can do those all day versus a huge inpatient stay. And we've seen that too, right? 30, 60 days inpatient that are really unfortunate events. And it does make you wonder if this person had access, easier access, like could that have been avoided? Review your current mental health benefit plan design and ask, where are the barriers? Do we really need these barriers? Is this something structurally that we can change within the plan design, or should we look for a point solution vendor? If we look for a point solution vendor, how can we make sure that what we're getting is data driven? We know what we need because we're making data driven decisions, not because they have a cool app or a cool flyer or whatever, but it's actually something that our people are going to understand and use and engage in. And then third, always coming back to compliance, you got to ask your carrier or TPA about the mental health parity, addiction equity compliance, and then consider that NQTL analysis, especially if you're a larger employer or you're self-funded. So there you go, guys. That was our talk today on mental health. I hope that little case study shows you that it's doable. And again, there's a lot of different ways to approach the mental health conversation. I think the last thing that I'll maybe end with, and it's not data driven, it's more personal. I can just say from my leadership experience, the more open that you can be with your teams about mental health, and that it's okay if somebody's struggling, and that you support them and that you see them and you value them and you are going to do anything you can to support somebody that's going through an episode of some kind, that goes a lot further, honestly, than any plan design decision could. That cultural component, right, of being a human and really valuing people. If you can't afford to change your plan design on your health plan, or you can't afford a point solution vendor, or whatever the reason is, you can control your culture. You can control how you approach these conversations. You can make it more of the norm. You do have that power at the very least. If you can do all of it, great. But if not, just think about on a human to human level, like how can I make this less of a thing in my company? And then there's some really great HR leaders out there, specifically one of our clients, Christina Ewing of Shoestring Valley Holdings. If you don't follow her on LinkedIn, she's very passionate about this topic, and Shoestring Valley Holdings has done some incredible work specifically on mental health within their plan. Maybe I'll get her on the show and invite her to come tell her story because it's pretty incredible. So go follow her for more tips on this. But anyways, guys, thanks. I appreciate you listening in. We'll see you in 2 weeks.